Good evening and welcome to the Spinal Cord Injury Forum. My name is Jeannie Hoffman. I'm one of the co-directors of the Northwest Regional Spinal Cord Injury System here at the University of Washington in the Department of Rehabilitation Medicine. The forums, the video recordings, and all of our online media content are made possible by a grant from the National Institute on Disability and Rehabilitation Research. Tonight we're very pleased to have with us several wonderful presenters, including Beth Hall, who's a rehab nurse at Harborview Medical Center. She's going to give us an overview on bowel management after spinal cord injury. We also have then followed by three individuals with spinal cord injuries, Joe, Eric, and Gareth, who are going to join us up here. And they're going to talk about their own experiences with kind of normal bowel functioning, and then what do you do when that's not working, and some other options. And we'll have, you will get to hear more about the experiences and then open it up to questions and answers after that. We're very grateful for them to be willing to share the information and their time with us. We're going to go ahead and get started with Beth Hall.
I want to thank you for asking me to come here tonight, and I want to thank Kathy Worms for helping me put this together. So we're going to talk about you and your bowel program and what you need to know to maintain success. What makes up a bowel program? A successful bowel program needs to be individualized. If it doesn't fit the person, it's not going to work because it won't be followed. A bowel program consists of some or all of the elements listed on the screen: diet, fluids, activity and exercise, medications, and bowel care itself. Bowel care is the actual process for emptying your bowel. That includes a schedule, when it's done, frequency, how often it's done, location and positioning. Is it in the bathroom? Is it in bed? Is it on a commode? Equipment that's needed, and the actual procedure for facilitating that bowel movement. This is where it gets individualized. Do you use chemical or mechanical stimulation, positioning, assistive techniques, digital stimulation, and the equipment needed for a bowel movement? So why is bowel management important? Surveys of people with spinal cord injury show that bowel dysfunction is one of the most distressing aspects of living with spinal cord injury. Establishing bowel function was ranked second in importance to regaining hand function for tetraplegics, and second to regaining sexual function for paraplegics. That's from a 2004 survey. More recent studies have shown a strong correlation between health-related quality of life and successful bowel management. So the central nervous system, how does it control bowel function? What does it do? It's part of the nervous system. The central nervous system is part of the nervous system consisting of the brain and the spinal cord. And you have this peripheral nervous system, which is part of the nervous system outside the spinal cord. It connects central nervous system to sensory organs like eyes and ears, and other organs, muscles, blood vessels, and glands in the body. Sensory impulses from the body's organs are transmitted to the central nervous system. Motor impulses pass out through the central nervous system to the body. These two symptoms, the central nervous system and peripheral nervous system, coordinate activities throughout the entire nervous system. So what's the effect on the bowel? The colon is controlled by many different nervous system pathways that must operate together in a coordinated manner for normal controlled defecation. The autonomic nervous system regulates colon peristalsis, which is the movement of stool through the colon. You need voluntary muscle control to maintain continence through control of the anal sphincters. And you need sensation for conscious control, as awareness of the presence of stool in the anus allows you to have time to get to the bathroom before the stool comes out. But even with central nervous system control, Without central nervous system control, the colon has this little mini nervous system of its own, the myenteric system, that keeps stool moving. So how's the bowel affected by spinal cord injury? Peristalsis in the colon slows down. It becomes sluggish. The sphincters, the control defecation, are affected. Depending on the level and completeness of the injury, determines the type of bowel dysfunction you may have. Reflexic bowel results from injury above the sacral segments, above T12. Areflexive bowel results from injury at any of the sacral segments. Incomplete injury at any level affects typical patterns of bowel dysfunction. And they may allow for partial or normal control over bowel movements. A reflexic bowel results in an interruption in messages from the colon to the brain. Below the level of injury, the spinal cord is still able to coordinate bowel reflexes. So you might feel the need to have a bowel movement. You still have reflexic peristalsis. Stool moves down, fills the rectum, and can result in reflex bowel movement without warning. Areflexic bowel, increased tone, it becomes flaccid, which can lead to stool incontinence. Peristalsis is sluggish and uncoordinated. A slow movement through the bowel results in dry stool, and manual removal is needed to prevent incontinence. Normal defecation. Stool moves through the colon, begins to fill the rectum. The rectal wall stretches, and that results in these waves of peristalsis throughout the colon. The internal sphincter relaxes, and the external sphincter contracts. And this allows for voluntary control of when and where a bowel movement occurs. Right after spinal cord injury, though, there's a complete loss of neural regulation of the gut. Reflexic bowels return after spinal shock, which is approximately 4 to 8 weeks, but can last longer. If you have a sacral injury, the reflexes do not return. These are some best practice guidelines, and even though they're from the late 90s, they're still relevant today. And you can download them if you go to the website of pba.org. And they're really helpful. So what are some long-term management goals? You want your bowel program to be acceptable. You want to be continent. Continence gives us control. You want a bowel management plan that is able to sustain itself. And no one wants to spend long hours having a bowel movement. You want it to be safe. Continence keeps the skin safe and prevents breakdown. And socially appropriate. Bowel continence prevents embarrassment, maintains personal dignity, and healthy skin. All of us want to take care of our bowel needs in private. In order to be successful, bowel care must fit your lifestyle and schedule, not take too much time, and help prevent health complications. I think this is a repeat. We'll move past that. So we know diet's important. Well, what about fiber? People talk a lot about fiber. Clinical practice guidelines recommend 15 to 20 grams of protein or grams of fiber a day. And you can get this in all kinds of ways. You know, there's lots of food with fiber. If you can find this on a website, you know, what's common? What are common sources of fiber? But if you eat too much fiber, it has been found to cause bloating, gas, pain, and slower transit time of stool through the bowel. The amount of fiber you use prior to the injury is usually the best indicator of how much is needed after your spinal cord injury. How much fluid do I need? Well, the clinical practice guidelines recommend, this is one of theirs, 40 mils per kilogram of body weight a day. That's a little over an ounce of kilograms per kilogram of body weight. And I tried to figure that out for myself, and I don't think I can reach that. But in addition to that, you have to have another half a liter. Then there's other studies that suggest maybe 1.5 liters is enough. If you take, if you're a large body type, it could be asking you to drink as much as 4 liters a day. And if you're working toward a successful bladder management program, I don't think it'll work. So a compromise is needed. You need to figure out what's going to work for both. Timing and routine. Bowel care should be scheduled at the same time every day or every other day. This helps for successful bowel retraining and is key to continence. Daily or every other day prevents overdistension of the colon, which can become chronic and open the door for future health problems. Eating food, drinking warm liquids approximately 30 minutes prior to bowel care helps stimulate the gastrocolonic response, which then leads to this mass peristalsis, which moves stool through the colon. Whether you have reflexic or areflexic bowel, establishing a routine helps to develop a predictable response. Equipment really needs to be padded, and it needs to fit you individually and support you. It'd be really nice if insurance paid for these things, but I don't believe they do. But this might be an investment you want to look at, because supportive padded equipment can prevent future skin issues. Medications. There's two kinds of oral medications. Those that help to regulate stool consistency and those that promote bowel motility. This is a list of what the reflexic and areflexic bowel programs need, bowel care. Areflexic is just manual removal of the stool. You need it to be firm and formed, 1 to maybe 3 times a day. And there's some assistive techniques you can use. Push-ups in your wheelchair, push-ups on the commode chair, abdominal massage, warm fluids, leaning forward, any way that you can help put pressure on your abdomen and help with pushing that stool through. Reflexic require a suppository, a mini enema, digital stimulation. You want the stool soft formed. It should be done daily or every other day. Assistive techniques are warm fluids or food, abdominal massage. And these recommendations, again, are in the late 90s, but they are still relevant today. Areflexic. So manual removal of stool means putting a glove on, lubricating your finger, putting it in the rectum, try and hook onto the stool and bring it out. Gently remove it. If the stool is firm and formed, it can be removed more completely. Because areflexic bowels have this flaccid rectal sphincter, firm formed stool helps prevent incontinence. And as I said, for successful areflexic bowel care, this process needs to be done at least daily, and you might need it 2 or 3 times a day. Reflexic bowel, you want soft formed stool. Rectal stimulation. Digital stimulation increases peristalsis and relaxes the external anal sphincter. To perform dig stim, you insert a gloved, well-lubricated finger into the rectum and then gently and slowly rotate in a clockwise position, making sure your finger touches the colon wall until that external sphincter relaxes. It relaxes, it allows stool to pass. What are some chemical rectal stimulants? There's the mini enema, enemies, and suppositories, bisacodyl, Ducalox, polyethylene glycol, or magic bullet, CO2, and just glycerin. How do they work? They stimulate the rectocolonic reflex, which helps propel stool through the colon. Because suppositories are slow to dissolve, bowel care may be prolonged. These are some common, the most common of the rectal stimulants. One is not any better than the other, but you may find one works best for you. So some of the characteristics of these are bisacodyl. It's the least expensive. It's easily and readily available, but it can cause overstimulation if it doesn't dissolve quickly. And this can lead to delayed results and mucous accidents. Polyethylene glycol, the magic bullet, dissolves faster. Thus it works faster, but it's more expensive. And then the mini enema, which works the fastest, minimizes incontinence. It's less likely than suppositories to cause mucous accidents, and it's least irritating to anal mucosa. Medications to regulate stool consistency. Stool softeners and bulking agents. Bulking agents, commonly the brand, Psyllium, Metamucil. And there's many foods, like I said, high in fiber. Moderate fiber is recommended. If you're using a supplement, the powder is preferred over tablets. Tablets are very dependent upon adequate fluid intake. Constipation and impaction can result from too much fiber or not enough water. Stool softeners. Docusate, Goscolase, these are the most common. They're over the counter, they're inexpensive, and there's very few side effects. Comes in 100 and 250 milligram capsules. Recommended dose is 100 to 500 milligrams a day. When you're figuring out what dose works for you, remember it can take up to 3 days, and some literature says up to a week, to see what effect on the stool a change has. If you have an areflexic bowel, but you still think you need a softener, titrate the dose carefully. Start with the lowest. Give it 3 to 5 days. If stool becomes too soft, it can lead to incontinence. And then there's the laxative, of which there are a few. These regulate bowel motility. 3 classes of laxatives. So they all work by increasing intestinal motility. You have the osmotics. They draw water into the colon by osmosis. They're like lactulose and Miralax. And you have the saline, milk of magnesium citrate. They draw fluid into the small intestine, and that stimulates peristalsis. And then there are the stimulants, Senna, bisacodyl, X-Lax, Cascara. These stimulate motility in the colon. Saline laxatives are a good choice for occasional constipation that has not been resolved with the osmotics. Stimulants chemically stimulate peristalsis, but chronic use can cause the colon to become sluggish or unresponsive to them at all. Some people may need a small daily dose of a mild laxative, though it's preferable for long-term management to use these only occasionally if needed for constipation. The first choice is Miralax. The second choice is Senna or milk of magnesia. Once you establish a successful bowel program, it may be possible to decrease any chemical stimulants you use and modify the program to make it as simple and successful as possible. Now, do you have an effective bowel care? Have you got that established? If you can say yes, then, keep doing it. Evaluate for improvements over time. Continue what you're doing. Recognize and manage complications. If you don't have an effective bowel care, then you've got to reevaluate and modify one element at a time. Elements that may need modification include diet, fluids, activity, frequency, position, type of rectal stimulant you're using, the oral medications you're using. But again, remember, just change one thing at a time. Give it 3 to 5 days to see what effect it has. This is the Bristol Stool Chart, which I think is great. Every day when I go to work, if I have a day off, I go to my patients when I come back and I say, so, did you do your bowel care? Yeah. Well, what did the stool look like? I don't know. How much did you go? I don't know. It's so important for you to begin to know what your normal is so that you can tell when something's up, when there's a change. You can be able to describe that to your healthcare provider, or you can see what the change is. There's some other ways to manage bowel care. Transient irrigation, which I'm not going to go into a lot of depth on because we have an expert on that. But there is one level 1 study and 3 level 4 studies that showed improved fecal continence, reduced constipation, reduced frequencies of UTIs, reduced time spent on bowel care. However, there was one case out of 211 where there was rectal perforation from it. This is the Peristine system, and that's made by Coloplast. And even though this is not covered by a lot of insurance companies, Coloplast is really working to obtain payer coverage so that those who may try it and like it can continue using it if they choose. Colostomy is another option. It used to be considered the procedure of last resort. But recent studies are showing that elective colostomy may be a viable option for many people. It's reduced time spent on bowel care, simplifies bowel routines, and can improve physical health, independence, and quality of life. Now, troubleshooting. These are things that come up or may come up, and what do? Let's look at them one at a time. Constipation. Constipation results in prolonged bowel care, small results, dry hard stools, or no stool for more than 3 days. What do? You follow these steps. You take these steps before or at the same time you contact your healthcare provider. You are or you will be your own expert. Develop this conceptual information toolkit so that you have the information, you know what to do if a problem arises. You can see increased fluids and activity. If you don't do bowel care on a regular basis, on a daily basis, start doing it. Review your medications. Maybe you need to make some changes. Add or increase a stool softener. Laxatives. Increase the dose of what you are taking, or maybe add a stimulant. Fecal impaction. That's no stool, or a small amount of liquid stool for days. If you think you have an impaction, try all the elements that you would do for constipation. and then add an ounce of mineral oil. If you have no stool in 24 hours, or if abdominal pain and distension develop, you need to contact your healthcare provider. Hemorrhoids or bleeding. Well, you need softer stool, so you might want to try milder stimulant. You need to do gentler and fewer digitals. There's hemorrhoid creams, ointments, suppositories, and even like tucks that you can buy over the counter. Check your commode seat. Check your seating on it. Because if it gets bad enough, you may require a hemorrhoidectomy. Autonomic dysreflexia, potentially life-threatening. Need softer stool. You need to change to a less irritating stimulant. Do gentler and fewer digitals. Also, talk to your healthcare professional and get some xylocaine or lidocaine jelly for lubrication to help decrease that pain stimulus. And keep your nitro paste on hand. Too much time spent toileting. Look at your diet, make some changes, increase activity, sit up for bowel care if you're not already doing it. You need softer stool, change the stimulant, more frequent bowel care. And if you have a reflexic bowel, gentler digitals. Incontinence. Accidents can happen, so prepare for the unexpected. Keep a change of clothes with you. If you need assistance with your bowel care, make a plan and identify someone who can help. But incontinence, you're going to hold stool softeners and laxatives. You're going to change the stimulant you use. Look at your diet. How regularly are you doing bowel care? And have you been sick? What's causing your incontinence? Kind of have to do detective work. Then there's diarrhea. So you want to hold those softeners and laxatives. Drink plenty of fluids, because prolonged diarrhea can lead to fluid depletion. Maybe you want to add some fiber, at least temporarily. If it's severe, you might want to just switch to the brat diet for a while, which is banana, rice, applesauce, and toast. If you want to take an antidiarrheal, take Imodium for a day or maybe 2. But if you're sick and have been on antibiotics, contact your healthcare provider and let them know what's going on. Mucous accidents. They're associated with suppository use, especially bisacodyl. But they can also occur from overstimulation with digitals. So avoid overstimulation and maybe change to a different suppository or try a mini enema. If you become familiar with these potential problems and the solutions, you can develop this toolkit that you can go to resolve problems on your own. It allows you to be more independent with your bowel maintenance. So what are some problems, possible problems, or reasons for these problems? Activity and exercise, decrease or stop. Maybe you don't have a home exercise program. Maybe you're not following it. Maybe you're not getting enough activity. One day you decide to take a break, and one day turns into 2 days, and pretty soon activity is way down. If fiber is being used, especially a supplement, it gets dropped. It's not tasty, it's not covered by insurance, but it's not replaced by dietary fiber. You stop using rectal stimulants and digital stimulation. These weren't normal before the injury, and you just want to be normal. Use of opiates, changes in medications. Changes in medications happen, but you may not realize the effect it has on your bowel, and that your bowel care may need some revision. Stopping bowel medications. The problem here is that the understanding of the actions of the different medications is not always there. It's so common to confuse laxatives and stool softeners. In summary, choose your bowel program elements based on your preference, your lifestyle, and level and completeness of your injury. Continence is attainable, but patience is required. Be gentle, not only with your bowel care, but with yourselves. If your bowel management isn't working well, change one thing at a time. Keep a bowel chart, keep a record of what you're doing and what effect it has on the bowel care you're doing. And again, develop this toolkit, these ideas of what to do if. And use the resources available to you. There's rehab nurses, outpatient clinics, healthcare providers familiar with spinal cord injury and bowel management. And you can get through this. Thank you for coming and listening. I hope I've been able to maybe answer some questions, give you some information you weren't sure about. But now I want to turn it over to the real experts.
Thank you, Beth.
My name is Joe Meyer. I live here in Bothell. I was injured about almost 9 years ago in a motorcycle accident. I do my bowel program over the toilet with a commode chair. I've been doing it that way for most of the time since I was injured. When I was first injured, I initially was doing it with digital stim, laying in the bed. But then, thankfully, I was able to transfer to doing it with the commode chair, thanks to a helpful nurse that was helping me at home after my injury. I use the mini enemas. We don't do any digital stimulation. We just put in the enema. Thankfully, I'm able to pretty much evacuate just with that. Sometimes it takes just a few minutes. Sometimes it can take half an hour or more. I do it every other day, just on a rotating basis. Occasionally I'll have incontinence, but that's usually because I've eaten some heavy, eaten too much, or eaten a lot of fatty food. Anytime we go out to eat at a restaurant, I have to eat half of the portion, sometimes a third of the portion that's given. But if I just kind of watch what I eat, as far as just quantity, usually everything goes pretty well.
Has there been a lot of changes over your 8 years?
Other than the change from doing it laying down in bed to doing it in the commode chair, no, not really. We pretty much stayed with that same program.
And are you able to do much of that yourself, or do you need help with
I need total assistance with it. So yeah, my caregiver helps me, transfers me onto the chair. We roll over the toilet, insert the enema, and then that's pretty much it. We actually shave me, do other grooming while I'm waiting to evacuate, and then we just wipe up, and I do my showers on the same night, and get back and go to bed. We do them in the nighttime, like I said, every 2 days. And yeah, thankfully that usually works. Some nights I have pretty normal output, sometimes it's minimal, sometimes there's none at all. I don't get too worried about it anymore if I don't have any output. I still stay on it every other day, and I'll just go to the next day or next 2 days, and usually things are okay by then.
So it sounds like your incontinence periods have been totally predictable for you.
Well, usually it's related to just eating too much in my case.
So, Joe, just in one other question, and I'll come back to you later because I'll have more questions once I hear from everybody else. But do you feel like there's things that that make it not great? Like, are you working or monitoring things in a way, or do you feel like you just have a smooth sailing system right now?
It's pretty stable. Like I said, as long as I don't eat a lot. I think I eat relatively healthily. I don't make a big effort to focus on eating a lot of fiber. I don't take any additional fiber supplements. I do take 100 milligrams of Colace 4 times a day, and I take 2 Senna each day. That's pretty consistent as well. I haven't noticed a lot of difference. I mean, I haven't varied that to experiment with different effects. So for me, that's kind of the stable program, and as long as I don't eat too much, I should be okay. But I guess I should say, though, lately, maybe over the last several months, I have had incontinence a little bit more frequently and a little bit more unexplained. And I can't really even tell you why it's happening more other than it is at this point.
So are you starting to kind of document and track some things?
Not really. It hasn't gotten too problematic that we've really thought about modifying anything at this point. We're still just trying to stick with what we've got going, and stick with the normal
routine.
Yeah.
Okay, great. All right, thank you.
My name is Eric, and I'm a C6 incomplete quad. I was injured about 23 years ago in a car accident. I just live down in Ballard. And I use it's the Peristine system, which is a irrigation system. And I actually brought Coloplast actually sent me the system if anybody wants to look at it, see how it works, how it all goes together after this. But I personally use the system once every other day. And on average, it takes about an hour for me to complete. I do usually have to manually digitally check myself once after the system's been done, complete, as well, to completely finish. And so that's, and actually just started the system because it is new to the U.S. Roughly about 4 months ago. So before that, I've always done suppositories, the magic bullet suppositories. And I've always had good results with that too. This is just something new that I decided to try and see if it improves, everything for me on it too. And it has been pretty beneficial for me overall. It feels like it's definitely a more natural way to go for sure over using a suppository. And it does take less time overall. Before, with a suppository, it's taking roughly around 2 hours to completely finish. Now this has cut my time in half by an hour. And it's something you do on a commode over the toilet. And being that I'm a quad, I have limited hand function, and the system is actually pretty well designed to do independently too, which is a huge bonus for people. It all goes together fairly easy, even with limited hand function. There's a couple cons to it too, though, as far as the price goes on it. It's definitely significantly more expensive to use over suppositories. You actually have to use a catheter every time you use the system, and so that's something that you have to purchase. They recommend it's basically a one-time use catheter. So you use the catheter and you throw it away. So there's a cost involved with every catheter that you use.
And is that because of just the stimulation that triggers your bladder too, or?
As far as using the catheter?
Mm-hmm.
Yeah, I mean, it's just because it's something that you're inserting into your rectum.
Okay.
So, I mean, you know, and then I think the catheter actually should be redesigned too, and something I want to bring up to Coloplast about it. I think it should be designed at a 90-degree angle instead of being just straight for insertion. So that's one change they should make to it. And there's a couple of cost factors involved where they require you to purchase a complete kit instead of being able just to buy the catheters. So that's something they need to change too. So it is a pretty straightforward system to use. All right. But I did bring a bunch of literature too that I put out there on the table if people want to check it out, kind of read up on it and learn more about it. Other than that, if anyone has any questions for me on it, I'd be happy to answer them.
Can I just ask a couple questions before we move on, and
Sure.
then we'll open it up for everybody? So over the 23 years that you've been injured, how many different things have you tried on your bowel program to get to the point of trying the Peristeen system?
I've actually used suppositories ever since from day one.
Mm-hmm.
It's something that I've done every other day, and like I said, it's something that it always gave me good results. I didn't like the time frame it takes to go through the whole process, and you know, so that was one benefit to you know, one of the main reasons I wanted to try the Peristeen, and because the Peristeen, like I said, it gives you more independence as well.
Right.
With the system.
Were you needing some assistance, or were you using like other devices?
I was using devices for suppositories. You can get like a suppository inserter,
Mm-hmm.
and also a manual digital stimulator as well. So I was you know, I'm independent with that, but this has made it a lot more easier for me to the whole system as well with the Peristeen over the suppositories.
Mm-hmm.
It's not as hard to use at all.
Mm-hmm.
So I'd recommend, especially if you're a quad, taking a look at this system
Mm-hmm.
over the.
Now, do you, other than the suppositories, did you take any other medications for bowel functioning?
I don't really take any medication. The only thing I do is take fiber supplements once a day, and other than that, I don't take medication at all, really.
And then that didn't change. You
No.
still take the fiber just as you always have, just to keep your diet similar.
Correct. Yeah.
Okay. All right. Great. All right. The introduction, please, sir.
Gareth Shu,
How long have you been injured?
1991. I was injured in 91, so what's that, 23 years? C4, 5, 6, they did a big fusion. It's incomplete, so I have fairly good use of my arms and hands. It's not 100%. But, for my first 10 years, I did bicicotal suppositories, digital stimulation. I was in and out of the bathroom in under an hour, usually to work within an hour and a half. So it was great. I had no complaints every other day. Started slowing down about 10 years ago, and the last 5 years had become really, really ridiculous. So it was sort of like a frog in the boiling water, you know. Apparently they don't know it until it's too late. I started realizing I was in the bathroom for 6 hours sometimes. And, you know, I had a laptop, and I had to change my work schedule, but it was getting really painful. So I tried everything that was gone through and more. Went to a naturopath, went to, witch doctors, anything. But the bottom line was it was just my digestion had slowed, my evacuation had slowed. I was never a very good pooper even before I was injured, so it was pretty random and slow sometimes. In addition, I developed a lactose intolerance when I was in college, so that made for some accidents. You can't always tell when you're getting sour cream in something, the Mexican restaurant or whatever. Did that give you the introduction?
Yeah.
Okay, there's an introduction. in March of this year, I bit the bullet and got a colostomy. And it's been just night and day. It was such a good thing. I wish I'd done it a couple years ago. So I'm an advocate for it, but it does have conditions. You have to have enough hand function to put the bag on, take the bag off, deal with emptying the bag. And one thing that has been a bit of a nuisance is I've had some mucus accidents. There's still a descending sigmoid colon segment of, they tell me 18 inches, that's attached to the rectum. And that has filled up with mucus a few times and, randomly exits, and I'm sitting in a pool of mucus, which is not a lot better than poop. It's maybe a little better, but I've been trying to diagnose why that is happening and figure out how to avoid it. A couple years ago, I was diagnosed with celiac, gluten intolerance. And after I had this colostomy, I said, well, what the heck? I'll go ahead and eat bagels and gluten and, pad thai and all of the stuff I hadn't been eating forever. And I started to realize that every time I have a big gluten bomb, I'll have a mucus thing. So, I mean, it's taken me a while. Listen, I've only been doing it for a couple of months. I'm sorry, what?
I said, so maybe you are figuring these things out.
I am figuring them out. But my doctors tell me that there's no way that colon is affected because the mucus, the gluten is not going through it. But it's still in my body. It's still receiving whatever is in the bloodstream. I don't know. I'm just looking at the calendar. I'm saying there's a cause and effect. So that's been the big downside for me. But knock on wood that there's a happy end to that. So, I get up in the morning and I go. My daughter's 8. She doesn't call me the guy in the bathroom anymore. It's great. It's been a big benefit for me. I could be on an airplane. I could be at a restaurant. Who cares? I'm pooping. I'm not pooping. It's just not really something I think about.
Okay, but I'm guessing you thought a lot about this before it happened. So what was the process to get you to the point that now you're really glad you had it, but leading up to this, how long do you think it really took from the point that somebody first said this could be an option, and what did you have to do to get to the point of saying yes?
It was actually almost the opposite of that. I asked a lot of people about colostomies, and a lot of people were pretty negative. They thought of it as, the last resort, and, there's problems, there's smell, there's, you really don't want to think about that.
So these are your medical providers?
Yeah. Okay. I hate to say it. I'm looking at one of them right now. No, she never would have done that. Nobody was a cheerleader for it until I met some ostomy people. I mean, the ostomy nurse, the ostomy doctor, surgeon, and they were very confident that it would change my life, and it's been true. There was about 2 months trying to find the right appliance. That's what they call the bag and the wafer, and it's basically a thing that sticks to your belly or your abdomen around the stoma. And I had a number of them that were sort of like super glue. They wouldn't pull off. I was taking skin with them. It's like, that's not good. Others fell off right away. So I've got one now that lasts about 4 or 5 days, and then I change it. And I get a little odor when it's time to change it because it's starting to separate, but it's not. I've never had a blowout. I don't. I've heard horror stories of them, but it can't be worse than a bowel accident, which I had way more than I would have liked. So, does that answer?
Yeah, so it sounds like you had to do some talking people into it rather than you talking yourself into it.
Yeah, and I really worked pretty hard to find people to talk to ask questions. It was hard to find wheelchair people that had a colostomy. There just aren't a lot of them. So that was very helpful to talk to people. Turns out there's all manner of colostomies. There's ileostomy, which is in the upper, the small intestine. I have the lowest possible colostomy almost at the end, which is, from what I understand, preferable for a number of reasons. But yeah, it was almost like I was trying to find people that would talk me into it, but then I was in the bathroom all the time. It was driving me nuts, and I was desperate. So this has been a big improvement.
Excellent. Beth, could you answer any of the, I was curious about, he was talking about the 3 different places, or the different places you could have from the ileostomy down. Can you speak to that, Gareth, or do you want me to try and get Beth to answer?
There's an ileostomy, which is at the end of or somewhere in the small intestine.
Right.
And the small intestine, as I understand it, is where a lot of nutrients are taken out of your food, but it's still very watery. Mm-hmm. So, and is it stomach acid? I don't know what. It can harm your skin if that stool is on your skin for any length of time. Mm-hmm. And the output is pretty watery. Then your stool goes into the large intestine and removes water, processes it some more. So the more time your stool spends in your large intestine, closer to your formal, the rectum, where it would go out anyway, the less it's going to harm your skin. So as I have stool into the bag, there's always a little bit of your skin around the stoma showing. And I have yet to have any problem at all. So they worry that if you have a lot of stool touching your skin for too long, it can harm your skin, and then you've got other problems.
Right.
So
lead to wounds, I would imagine.
Yeah. That's the short answer. Okay. I know there's ostomies for peeing and I don't know, a number of other things.
Right. Absolutely. I am going to open it up for questions from everybody, and I think that the way that I'm going to do this is just stand behind you all and move this around for you. So I apologize. This is going to be a little low tech, but that's okay. We've done this before. It's not the first time. So questions from the audience. What kinds of questions do you have for any of these folks? Beth, Joe, Eric, or Gareth? Yes. So the question is that if you have the colostomy, would it be reversible?
Yes, and the surgeon that I went through at the U said that almost all of them are reversible unless there's a situation of cancer where they have to be taking big pieces of your digestive tract out, including possibly the rectum itself, which is not a scenario that anybody wants. So physically, I'm still intact. I could ask them to reverse it. They do it all the time with people that have Crohn's or colitis. So yes, it is reversible.
So the question is, you mentioned that you did digitals early on, but now you don't. Did you stop doing them because of discomfort, or just not need them, or what changed?
Well, I mean, mainly it just made it easier not to do them, to find caregivers to do it. Obviously, it's less invasive. It's less invasive. It was just easier, and I was lucky enough. I should have mentioned that before. I mean, I think my bowel program is pretty straightforward. It's been pretty steady, and the fact that I just do the mini enemas with no digital stim, and I'm able to go on my own. I can tell. I've got enough sensation that I can tell when I'm done. I can tell when I'm not done. I can tell when I'm just wasting my time sitting there any longer. And yeah, I just don't need them, so I don't see the need to do them. And I've been able to get away without doing them. So just one less thing to worry about, basically.
Beth, is that something that happens for a lot of people, of changing from needing digitals to not, or vice versa?
I'm not sure if it happens a lot, but I think it's part of that. Once you establish bowel care that works, and you want to you got something that works, but you want to simplify. It's something that can be looked at and maybe stopped. Maybe it won't have any effect.
I think some of the decision whether you need to continue digitals or not may depend on the completeness of your injury, and also whether you have sensation or not.
So speak to that.
So what
Tell
else?
me more.
Tell you more. People with incomplete injuries may not need as many of the tools in the toolkit as people who do not, or as people who have complete injuries. So I think digitals are more important if your injury is complete.
So, given that you have mentioned that you've had a few more accidents, would you think about going back to using digitals?
I don't think so at this point. It doesn't, I guess I should describe for me when I have accidents. Sometimes I can literally just be sitting in my chair. Everything seems fine. I haven't had any particularly large meals. And then all of a sudden, I can feel my guts churning and things moving, and sometimes it's just a matter of minutes. And I don't have time to get on the toilet. My wife, I don't even have time to get over the toilet, and it's too late. But I don't think it's because I'm not emptying fully, or that sometimes I've had accidents the next day after a perfectly normal bowel movement. So they're kind of inconsistent reasoning behind them. So again, I don't think it's, for me, I haven't thought, it's because of the digitals. I don't know, I'm not really sure what's going on. But it just seemed, normally I'd have maybe an accident maybe once or twice a month, maybe once a month. Now it's more like maybe twice a month. And yeah, sometimes now it's not always related to how much I've eaten or what I've eaten. That's what I've always attributed it to in the past. If it gets more problematic, then yeah, I'll probably start to do more investigation and see what we can do about it.
Data collection is what I recommend.
And along with data collection, you said you were taking Senna every day? But doing your bowel care every other day? I mean, my first suggestion to you would be consider taking the Senna every other day and taking it the day before you do your bowel care.
So first recommendation. Other questions? I have a question for Eric on the Peristeen system. Can you, where did you even learn about it, and how did that even come up?
The first place I learned on it was on a forum, actually, the CareCure forum. It's a good place to get in and get different, options and learn about a lot of different things. So that's the first place I heard of it. And it's been available in Europe for quite a few years, and it's just now, from what I understand, just now getting introduced over here. So I don't know if there's a lot of people doing it over here.
The question is whether or not you can, whether it changed from an every other day program. Did it change with the Peristeen?
Yeah, I've kept it consistent with my routine. Every other day has always worked for me. I guess some people with the Peristeen have actually said that they've actually done every 3 days because it cleans them out pretty well. So, but for me, I've just kind of stuck with what I know works for me, and so.
And there was no recommendation to change that?
There was no recommendation for it. I guess I'm pretty in tune with my body and how I feel, so every other day just feels right for me. So I'm sticking with that, yeah.
You mentioned that there's some recommendation you make to the company about things to change in terms of kind of how it's used. Have you had to make any modifications just to make it more accessible for you?
Actually, yeah, I have. I actually did, because the tubing is pretty flexible and the catheter is just a straight. And I think they really should redesign either the tubing where it connects or the catheter at a 90-degree angle. It just makes more sense for inserting it when you're sitting down. So I actually did my own modifying to the tube to actually make it more at a 90-degree angle. So yeah.
Any other kinds of changes you've had to make?
No, the rest of the system is actually pretty well designed for the way it all connects together, even for limited hand function.
Actually, one of the things that we didn't talk about, we talked about medications and stuff, but what kind of actual surfaces are you guys using? Joe, did you say you're on a commode chair, or kind of what did you use?
Yeah, I use just a regular shower commode chair on wheels. My caregiver transfers me to the chair. We roll it over the toilet. And the caregiver has to do all the insertion of the enema. I can sense what's going on, but I'm not able to assist in any way.
Is it padded?
Yeah, it is padded. Probably not padded as much. I know I've seen, mine's just kind of got, foam. Trying to think what it would be comparable to. Less than your basic stadium seat. So it's a little bit harder than it probably should be. Thankfully, I haven't had any skin issues, but I know my legs go numb if I've been sitting there funny, not quite in the right position. My leg and my foot will go numb. So I've definitely been considering getting a much nicer padded seat cushion at least to sit on.
I've heard they have some Cadillac versions. How about you, Eric?
I use a shower commode chair. Yeah, so it's just your manual chair pretty much for a shower chair. So.
And how padded?
It's padded. It's really padded. It's a good chair actually.
And how often have you had to get a new one?
This one I've had for about going on 3 years, I think. So I'd say about close to every 3 to 5 years I'd probably do it.
Have to get a replacement?
Yeah.
Has that been true for you too, Joe?
Sadly, I've not replaced mine at all, so it's like 8 years old, which is probably another reason. And it's been real, it's been in really good service, but yeah, it's definitely seen better days at this point.
And that might have something to do with the padding too. All right, how about you? Gareth?
Yeah, I used a padded commode, shower commode chair, and that was the first thing I did when I got home from colostomy, was take it apart and throw it away. So I was really pleased with. No, I still have one that I use for showers, and if I have to do a little irrigation or cleanse from the mucus, I'll use that for doing some enema, just water enema.
Right.
But yeah, I mostly I'm just in this chair, and if I start feeling like this bag is getting full, I'll empty it, and I don't use a shower commode chair other than taking a shower.
Right. I
So.
see. And how often did you or typically replace yours?
Oh, the shower commode chair? 5, 6 years. The fact that I don't remember the brand tells you how often
Right.
it is. Yeah, it's not often.
Okay.
They're pretty durable.
So no bonfire, but kind of.
I would have driven over it with the truck if I could have convinced my wife to do that.
But you might have popped a tire.
It would have been worth it.
It would have been. Other questions that people have? Given that the system works like an enema, how do you decide how much water to put in? How did you figure that out?
Just basically trial. Just when I first got the system and took it home, it gives you up to 1,000 cc's to fill it up with water lines in different increments. So I just started out with a couple hundred cc's and to see if it would really empty my system out. And from there, I just kind of slowly increased it till I got to the right level where I felt like it was completely emptying out my system.
Why did you come up with that? What number?
What was your final number?
My number is, I ended up about 900 cc's.
can you explain that a little bit? So the amount has to do with just being able to fully empty, or?
Right. Yeah. It's basically you have like a little hand pump, and you pump it into your system, and then you know after you take the catheter out, you know that can take anywhere, like I said, from immediately to up to an hour. It completely runs out of your system. So you know when it completely comes out, you can feel it.
I just want to add something about the way the peristine is supposed to work. Is that it's supposed to be a nurse is supposed to help you determine what's the correct amount of fluid, and also make sure you don't get dysreflexic at the time. There's supposed to be training sessions. Eric chose not to do that, right?
Well, I did come into the clinic and they showed me.
You had one training session? Okay, yeah. Yeah, it's supposed to be at least one or two, just for the safety of the system.
Yes.
In addition to that, Eric, you hit your intensive rehab.
So in addition to coming into the nurse, you also have some backup?
Yeah, I mean, I am in contact with Coloplast on it. If I have any questions, I just send them a quick email or phone call, and they're pretty quick about getting back to me.
So the question is, actually, all three of you, right, were on an every other day when you needed to be, but the two of you are on every other day. Is that more common, every other day than daily? And what are the decisions around that? And I don't know if Beth, do you want to take that, or Kathy?
I know inpatient, we try for every day to begin with. And then we really did try to go every other day, and it's for convenience and simplicity, I guess, with that being the goal. It doesn't always happen inpatient, but I think people look to try it, look to go to that later on. They're so new still in inpatient.
Just to save time.
Save time, yeah.
So a lot of people end up leaving inpatient with daily bowel programs. It sounds like a lot of times, maybe attempting to shift it to every other day. Kathy, can I ask you, on the outpatient basis, is that something that is a regular thing that you talk to people about transitioning to, and what are the factors that might one person figure out about when to keep it every day and when to go to every other day?
We pretty much, it's an individual decision, and it is based on how frequently do you need to do it to feel well. Some people, if before their injury had a daily bowel movement, would want to continue having a daily bowel program. Some people prior to injury would not go that often, and so they would want to transition to the every other day. Way back in the day, we had people that would transition to every 3 days, but that really turns out not to be healthy in the long run. Seems to set people up for constipation and other complications. So I think you need to decide for you whether it's, whether you feel better at daily or every other day, and then to make the transition to every other day, you would basically just want to make sure that you have results every time. Because if you don't, then you really set yourself up for constipation.
So the question is given differences in women's anatomy versus men's, is there a recommendation on doing kind of just a normal classic bowel program versus peristine versus colostomy that would be more appropriate to reduce infection risk for UTIs? Beth, do you want to start with that one, or you want me to defer to Kathy?
I know colostomies do decrease the incidence. Yeah.
Are there, go ahead.
And the studies on the peristine or the transient irrigation show that they also decrease the incidence. So those two options would be more likely. But there's no reason that a classical bowel program needs to be avoided. It just needs to be done carefully, and hygiene needs to be done carefully. Most importantly is avoiding constipation, because actually constipation can increase your risk of UTIs more than any of the other things.
So if you are needing help with bowel issues, who do you see? What kind of physician do you see?
I'd see any of the rehab doctors in the spinal cord injury clinics, either UW or Harborview. I would imagine there might be some primary care people who could help, but probably not. It's more of a specialty field for neurogenic bowel.
Gareth, who did you end up then going to see? I'm assuming you were referred from the docs in either your primary care or rehab, and then who did you go to?
Kathy and Diane Britt referred me to the wound ostomy clinic in the surgery pavilion here at the U, and I met with Yvonne, who then put me in touch with Colleen Carvonen, who's the wound ostomy nurse, and they introduced me to Dr. Alejandro Fiquera, who's a great Italian surgeon here, and he did the actual cutting. Yeah, it's a great group. They're very capable, and I recommend going to them to ask questions. They were a wealth of information that a lot of other people don't seem to have. So.
And I don't know why I didn't say this before. You asked about doctors, but really you should talk to the nurses in the clinics, or the nurse practitioner Joanne at Harborview.